Welcome back, everybody. We're on part 2 of chapter 11 of the muscular system. We're looking at the appendicular muscles of the upper and lower extremities. So this is all fair game for quiz number 7. I will try and use slides that will have the muscles in bold view, in the bold print, although any muscle technically on the slide is fair game, but I'll try and make it as plain as day for you guys to identify certain muscles. So let's look first at the pectoral girdle. We're going to look at muscles that are going to help either move or stabilize the scapula or the clavicle, in some cases partially the humerus at the same time. So let's look at a couple muscles here. First, the anterior muscles. Let's look at the subclavius, which is going to be found just as you would imagine, judging by the name, underneath or just inferior to the clavicle. It's going to help depress the clavicle and also assist in forced exhalation. It's a reverse muscle action muscle where basically if one side stabilizes, it can actually pull in the opposite end. So in this case, your arch insertion are going to flip. Subclavius muscle is going to be innervated by the subclavian nerve, so pretty easy to pick up on that. Next, we're going to look at the pectoralis minor muscle. So as you would assume, if you have a minor, you would have a major too. Most people are aware of the pectoralis major. The two muscles do have two totally different motions though. For pectoralis minor, this is also a reverse muscle action. This one will help abduct the scapula, but it'll also aid in pulling the scapula downward to stabilize up against the ribcage. When that is further stabilized, the pectoralis minor will also assist in forced inhalation to try and draw the ribcage out and up. Next muscle, a little more inferior, is the serratus anterior. This will also abduct the scapula, but also at the same time, it'll work as an antagonistic muscle or opposing muscle to the pectoralis minor. The serratus anterior will actually help rotate it upward, rotate the scapula upward at the same time. Let's look at some of the posterior muscles. In particular, we're going to look at the trapezius. The trapezius muscle is going to have a bunch of different motions with it, as it's going to attach from the occiput through the cervicals, and it's going to attach out laterally to the scapular spine, and also as it tears back down through the thoracic spine down to T12. The trapezius, depending on what muscle fibers that we're talking about, the trapezius will have superior and middle and inferior fibers. So as you imagine, the superior fibers will upwardly rotate the scapula, the middle fibers will adduct the scapula, and the inferior fibers will also help depress and upwardly rotate the scapula as well. This muscle is very well knotted up, and we see a lot of patients that are stuck in that forward hunch position that we find ourselves in front of the computer. Most of your superficial muscle knots are going to occur in the trapezius because it's almost always active in any kind of posture move that you have, whether sitting or standing, and occasionally this can kink too while you sleep, especially in those really deep stages of sleep where it gets very little motion. Just underneath that, or just deep to that, is the levator scapulae. Levator scapulae muscle is going to attach from the cervical the transverse processes of the cervical spine down out to the superior vertebral border of the scapula. It's basically going to help elevate the scapula and also rotate it downward. Next you have, which is not shown on the slide here, is the rhomboid major and minor. Rhomboid meaning very diamond shaped. These work in conjunction with one another. They're going to attach from the vertebral border of the thoracic spine and attach to the medial border of the scapula. Both will help elevate and adduct the scapula. Because it's going to be in a diamond shape, the fibers do run from the medial to lateral. Also, they angle downward, down towards the inferior portion. So these will help adduct the scapula as well as elevate the scapula to some extent. Now let's talk about nerve innervations with each of the different areas. Subclavius will have the subclavian nerve. The pectoralis minor will be innervated by the medial pectoral nerve. The serratus anterior is going to be innervated by what's known as the long pectoral nerve. The trapezius, in conjunction with the sternocleidomastoid, will both be innervated by the accessory nerve number 11, which is a cranial nerve. The levator scapular muscle, as well as the rhomboid major and minor, will all be innervated by the dorsal scapular nerve. Technically, levator scapula is also innervated by portions of the cervical spine, but let's talk mostly about the dorsal scapular nerve, those three muscles. So again, dorsal scapular nerve, just think of dorsal meaning back, scapula meaning the shoulder blade, is going to innervate the levator scapulae, the rhomboid major, and the rhomboid minor. And here's the chart with basically the information that I just talked about. Now, occasionally, though, the serratus anterior muscle, if you notice how the serratus anterior muscle is named, It's very sawtooth. If you notice, it's actually partitioned along different ribs. Some people either ribs 1 to 8 or sometimes ribs 1 to 9. It's the reverse muscle action helps elevate the ribs when the scapula is stabilized, but also it's known as the boxer's muscle because that keeps the arm in a horizontal position, so as when you're punching or pushing. So this is one of those muscles a lot of times that gets weak when we see a lot of patients, again, in the forward hunch position, where we find ourselves in a seated position for a long period of time. I have people do straight arm push-ups sometimes to help work on this particular muscle to help stabilize the shoulder blade. And when we get into the spinal nerves in particular, when we start to see certain kinds of injuries, you may get what's called a winging of the scapula, where it kind of flares outward. So it usually means the serratus anterior muscle is very weak. Fortunately, it's a relatively easy fix. Just take some repetition to really kind of get the muscle, help stabilize the area. Looking at the posterior thoracic muscles, again, trapezius, again, a very broad, very thick muscle, one of the major muscles of the posterior cervical and thoracic spine, again, innervated by the accessory nerve. Next, we're going to look at the muscles that are going to move the humerus and portions of the shoulder. So let's look at the most superficial, most lateral muscle right now, looking at the deltoid muscle. The deltoid muscle is going to be innervated by the axillary nerve. It's going to have 3 partitions. You're going to have an anterior, a middle, and a posterior portion of the deltoid. The anterior is going to help flex the humerus. The middle portion, or the lateral portion, is going to help abduct the shoulder, and the posterior portion is going to help with extension of the shoulder. If you go a little further down, you look at the supraspinatus muscle, one of your rotator cuff muscles. There's not a great shot of the supraspinatus, but that also will help abduct the shoulder. It's actually the initial muscle that starts the motion, and then lets the deltoid take over just after that. But I'll show you a better picture of the supraspinatus in just a few minutes. Next, a little further down, look at the subscapularis muscle. There's a real deep muscle that's going to be in the subscapular fossa of the anterior portion of your shoulder blade. It's going to be sandwiched up against the rib cage. The subscapularis muscle will help stabilize the shoulder blade or the scapula to allow the proper motion of the humerus bone, especially in the act of throwing or doing push-ups. It's a very strong medial rotator of the humerus. Next, we're going to look at the coracobrachialis muscle. We'll go more in depth with subscapularis in just a few minutes. But let's move on to the coracobrachialis muscle. This is going to also help flex the humerus, or flex the upper arm. The pectoralis major muscle we'll talk about on another slide or two, but this is a major muscle that will not only medially rotate the arm, it'll also deduct the arm. It will also help flex the arm towards the trunk. This is a very strong muscle, which is going to be sometimes opposed by the latissimus dorsi, although the latissimus dorsi and the pectoralis major muscles will kind of work in sync, especially when it immediately rotates the arm, and also when you're looking at a deduction of the arm there as well. The one thing that does oppose the pectoralis major with latissimus dorsi does help with extension. So a lot of times what we see, especially with patients in particular, is we see, because we spend a lot of time with our hands in front of us, the arm is going to be flexed and also adducted. So the latissimus dorsi as well as the pectoralis major will hold those particular arms in place in that particular position, and that weakens a lot of the muscles that oppose them, which we'll get into on the posterior muscles. But they include parts of the trapezius, part of the rhomboids, part of the levator scapulae, as well as some of the rotator cuff muscles. But the latissimus dorsi, the pectoralis major, and also in conjunction with the subscapularis, these are all major medial rotators. The latissimus dorsi and the pec major will also help adduct the arm at the same time. Next, you're going to look down and see the teres major. The teres major basically will work in conjunction with latissimus dorsi, helps with medial rotation, and also will help with extension of the arms there as well. In fact, when you look at the posterior view, it's going to be found just tucked underneath the latissimus dorsi muscle in particular. So let's talk a little bit about some of the innervations. Again, with the deltoid, it's going to be innervated by the axillary nerve. The supraspinatus muscle is going to be innervated by the suprascapular nerve. Going further, the subscapularis muscle is going to be innervated by both the upper and lower subscapular nerve. Coracobrachialis is going to be innervated by the musculocutaneous nerve, which we'll talk about that in just a little bit. The musculocutaneous nerve is going to innervate a lot of the anterior muscles of the humerus. coracobrachialis being the other major one. Your pectoralis major is going to be innervated by the medial and lateral pectoral nerves, very similar to the pectoralis minor. Teres major is going to be innervated by the lower subscapular nerve. So it's very simply because it's going to be lower than the actual scapula itself, it's going to be innervated by the lower subscapular nerve. This is a great slide that shows the posterior muscles of the shoulder and the humerus. If we look to the left there, it shows a nice shot of the deltoid muscle, especially the lateral and the posterior portions. So along with the anterior portion of the deltoid, it'll taper down to a central tendon that will attach to the middle diaphysis at the deltoid tuberosity. The deltoid muscle is a relatively strong muscle, but also tends to also be very spastic in the anterior portion, because as I mentioned before, most of us find ourselves in the forward hunch position. So it's like a tug of war between two heads of the deltoid, the anterior and the posterior. The lateral is pretty much all along for the ride. The anterior portion of the deltoid tends to get very strong and actually weaken the posterior portion. So for a lot of patients, when we start having kind of shoulder problems, the deltoid muscle is a very tough muscle to stretch on its own. So we usually try and incorporate some kind of rehabilitation where it works the posterior muscle. So we tend to do a lot of lateral rotations, a lot of extensions to integrate the posterior portion of the deltoid and try and offset some of the pressure we're getting from the anterior deltoid. You'll see too, just below that, or just inferior to that, you'll see the teres major. So teres major is just going to be superior to the latissimus dorsi. We see a nice broad spectrum of the latissimus dorsi. It spreads the entire sweep of the back. It has a very strong attachment to the thoracic and lumbar spines through the thoracolumbar fossa. Very strong muscle that, besides medially rotating the arm, helping with extension, adduction, also will help elevate the lumbar and lower thoracic spines. So those of you who've ever done pull-ups before, proper technique does involve the lower back to provide full contraction in the lats, although I have seen plenty of people hurt themselves by doing too quick of a jerk motion or involving too much of the lower extremity. But again, latissimus dorsi, very important muscle for not only the arm but also for the lower back. Flip to the middle part of the most medial part of the spine, you'll see the rhomboid major and minor muscles, which are going to be diamond shaped. You're going to find these going to be attached to the upper thoracic spine as they project both inferiorly and laterally to the scapula. These are going to be major muscles that help retract the scapula and try to draw them back. It also will help kind of project or actually rotate the rotate the arm or rotate the scapula in a downward angle. So what that'll do is going to pull the inferior angle of the scapula in a downward motion. So it actually will allow the scapular spine to rotate upward and laterally. This is important because it helps provide proper stabilization for the shoulder blade to in turn let the rotator cuff muscles take over there as well. So there's also a nice little shot of the rotator cuff muscles in particular. We're going to have the four muscles that make up the rotator cuff, and I'll show you next slide exactly what they look like here. But you get a little glimpse here. You have the supraspinatus, which is going to be the supraspinatus fossa, just above the scapular spine. This will aid in abduction of the shoulder. In fact, that's what takes over first, and let the deltoid take over just after that. You have the infraspinatus and the teres minor. The teres minor is going to have a slightly different motion than teres major, so it's very important to keep those two distinct from one another. The infraspinatus and teres minor in some cases may be fused or may be very tough to differentiate from each other. They actually do almost exactly the same thing. They'll help laterally rotate the humerus. So these are constantly fighting against the pectoralis major, the latissimus dorsi, and teres major, as well as the subscapularis, another one of the rotator cuff muscles. So these also tend to get very weak with postural issues there as well. So let's go to the next slide and take a look at the rotator cuff muscles here. Also, a nice little shot of the triceps brachii. We'll talk about that in just a few minutes because it has two secondary motions besides working on the elbow. So here are the rotator cuff muscles. There are four. The rotator cuff muscles are going to include the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. So it's those four muscles we call the sits muscles, S-I-T-S. So it's important to remember it's the teres minor that is part of the rotator cuff, not the teres major. Now the supraspinatus muscle is going to be innervated by the suprascapular nerve, The infraspinatus muscle, also innervated by the suprascapular nerve. The teres minor, just something I have to memorize. I don't have a good way for you guys to remember this one, is going to be innervated by the axillary nerve, very similar to the deltoid. And then the subscapularis, like I mentioned before, is going to be innervated by the subscapular nerve, both the upper and lower portions. Let's go over the functions real quick here. So again, your supraspinatus, probably the one that's mostly torn with most rotator cuff injuries, more so than the other three. The supraspinatus is going to help in abduction. Your infraspinatus and teres minor, again, are going to do the exact same function. In fact, you see how they're attached to the lateral portion of the humeral head. They're going to help laterally rotate the arm, or laterally rotate the humerus, whereas the subscapularis can be found on the anterior deep view, is going to oppose the infraspinatus and teres minor, and it's going to aid in medial rotation of the shoulder or of the humerus. So again, quick review. So the pectoralis major and latissimus dorsi are going to be the major muscles that are going to be axial muscles that move the humerus. So the pectoralis major, just remember that it's going to adduct, medially rotate the arm, and also help kind of flex the arm to the side of the trunk, innervated by the medial and lateral pectoral nerves. The latissimus dorsi is going to be antagonistic only from the standpoint that it's going to help extend the humerus, but it's going to work in conjunction. It's going to be a synergistic muscle with the pectoralis major. It's going to adduct and also aid in immediately rotating the arm. It'll also elevate the vertebral column, and the torso is going to be innervated by the thoracodorsal nerve. Looking at the scapular muscles, deltoid again helps with abduction of the arm. It'll help partially flex, also help partially extend the arm at the same time, depending on which part of the deltoid is aiding that particular function, innervated by the axillary nerve. Your four rotator cuff muscles again, subscapularis, supraspinatus, infraspinatus, teres minor. Unfortunately, I don't like the way this chart is set up. Teres major is interspersed there. The teres major is not one of the rotator cuff muscles. Again, the teres major is not one of the rotator cuff muscles. Subscapularis, medial rotation of the shoulder and the arm, innervated by the subscapular nerve. Supraspinatus and infraspinatus. Supraspinatus is going to be the major abductor of the shoulder joint, suprascapular nerve. Infraspinatus is going to laterally rotate the arm, suprascapular nerve innervating. Teres minor, skip the major for a second. The teres minor works in conjunction with infraspinatus, laterally rotates the arm, also, but will be innervated by a totally separate nerve, the axillary nerve. Teres major is going to assist with latissimus dorsi by extending the arm and also assist in adduction and medial rotation of the arm. Is going to work with the lower scapular nerve, and of course the coracobrachialis muscle. You'll find this just deep to the biceps brachii. It's going to flex and adduct the arm at the shoulder joint. It's going to be innervated by the musculoskeletal or musculocutaneous nerve. So next we're going to look at the muscles that are going to move both the radius, the ulna, and also partially, you'll see here too, also helps partially move the ball and socket joint of the humerus and the scapula. So looking at the diagram on the left, you're going to see a nice shot of the two heads of the bicep, the long head, the short head. The long head is going to insert deep into the glandular cavity of the shoulder joint, whereas the short head is going to attach to the coracoid process of the scapula. The biceps brachia has two major functions. It'll flex the elbow. It'll help partially supinate the form of the radial ulnar joint, but not completely. But also what it does too, the full motion for your bicep will also help flex the shoulder joint at the same time. So full flexion of the bicep is going to include full flexion of the elbow and also full flexion of the shoulder as well. There's not much more to contraction that happens there, but there is some contraction there at the same time. Those of you who are done curls or done incline curls, to really get a full stretch on the bicep and get a full contraction, you are going to have the arm angled backward into extension or hyperextension, roughly 30 to 45 degrees, and curl the dumbbell all the way up, and also flex the shoulder all the way up there as well. When I have patients that have any kind of bicipital tendonitis, especially in between the two tubercles of the humerus, I'll have them do that kind of motion, not for strength, but to allow the tendon to slide back and forth properly along that intertubercular groove. Biceps brachii is going to be innervated by the musculocutaneous nerve. Just deep to that is going to be the brachialis muscle. The brachialis muscle does not attach over the shoulder joint, but does aid the biceps brachii in help flexing the elbow at the same time. This also will be innervated by the musculocutaneous nerve and partially by the radial nerve, but I'm not going to hold you guys to that. Just simply say musculocutaneous nerve, and that's fine for me. those are the muscles that help flex the elbow. Now, look on the flip side or on the right side, look at the triceps. So naturally, if the biceps has 2 heads, the triceps would have naturally 3 heads. So you're going to have a long, a lateral, and a medial head. So the long head is going to attach to the most lateral portion of the scapular border, the lateral border. The lateral head is going to attach just posterior to the humeral tuberosity. Probably not tuberosity, but simply the posterior elements of the humeral head. And will then attach into the olecranon of the ulna. So the tricep is going to have 2 functions as well, besides extending and hyperextending the elbow in some cases. It also partially will extend the ball and socket joint of the shoulder or extend the humerus at the same time. Now, if you look just distal to that muscle, you have what's called the anconeus muscle. This also will aid in extension of the forearm at the elbow joint, but not everyone has the anconeus muscle. There's a small portion of the population where this muscle is missing. Both muscles are going to be innervated by the radial nerve. And what we'll find very simply is the radial nerve is a very long, very large muscle. Actually, it's the largest nerve, of the upper extremity. It'll innervate most of your posterior muscles. So again, if you had to guess, if you have a muscle that's on the posterior portion of the upper or the lower portion of the upper extremity, if you guessed the radial nerve, you most likely will be right. This is a nice little transverse section of the upper arm, the brachial area. So if you remember from the last video we had done for part 1, for most people, or I'm sorry, most humans, you're going to find that the biceps in general is going to be a little bit stronger, have a better cross-sectional area than triceps, but all kind of depends on where you make that cross section in particular. The higher you go up, or the more proximally go up through the arm, the triceps, especially very close to the ball and socket portion of the shoulder, will seem thicker, have a better cross-sectional area. But then if you go more distal, especially down past mid part of the diaphysis of the humerus, you'll notice that the bicep muscle will actually have a better cross-sectional area, and for most of us tend to be stronger in that regard. Most quadrupeds, though, you'll find this to be just the opposite, where pretty much the triceps will, for the most part, have a better cross-sectional area than the biceps. Okay, now as we go a little deeper into the upper extremity, especially at the elbow joint, so you're looking at the brachialis muscle. So we're taking the biceps away and have a nice flat, broad muscle called the brachialis muscle. Is going to help flex the elbow. That's on the anterior deep view. Go a little further down, you have what's called the brachioradialis muscle. That kind of tells you where it attaches the origin as well as the insertion. The brachioradialis muscle is very important. It's known as the drinking muscle. So very simply, if you guys remember supination, pronation, it's the brachioradialis muscle that brings it back towards midline. Unfortunately, I don't have a quick video for this, but under Wiley Plus, going through different muscle groups, it'll show you how that works. But if you think of it this way, when you actually hold a glass or a mug of something you're about to drink, basically your hand is basically in a neutral position. So the thumb points straight outward, will point straight up. So make sure that the glass is level. That's the one that aids in actually flexing the elbow so you can actually drink from the cup. Those of you who are Game of Thrones fans, if you guys remember Cersei, she's always drinking Arsenian red. So it's that brachioradialis muscle that she's using constantly as she drinks. Looking at the 2 diagrams on the bottom here, so these are going to be your major supinators and pronators. So in the posterior deep view, so your supinator is going to be innervated by the radial nerve. It's going to be found on the posterior section. It's going to be a supinator, so if you think of it this way, so on the posterior, it takes your hand from the palm down position, flips over palm up. So it's a very strong supinating muscle called the supinator, again, innervated by the radial nerve. Now on the flip side, on the anterior deep view, there's going to be 2 muscles that help you pronate the forearm. You have the pronator teres, which is going to be found more proximally, and the pronator quadratus, which you find more distally. Strange enough, the pronator quadratus in particular, we find this muscle to be in spasm quite often. We find this to be mistaken for like carpal tunnel-like syndromes. The pronator quadratus, a lot of times when doing mouse work, especially with the old school mouse pads, a lot of times puts pressure on the muscle, and a lot of times it can scar up, get very tight, and actually constrict the carpal tunnel and the rest of the areas of the wrist. The pronator teres and the pronator quadratus are going to be innervated by the median nerve. And I'll show you at a later date how to differentiate between the different nerves in the forearm as well as the upper arm. Most of your posterior muscles, like I mentioned before in the last slide, innervated by the radial nerve. The proximal portion is going to be mostly the musculoskeletal as well as the axillary. When you get down into the forearm, which we'll see in the smaller partition of the muscles, it's going to be either median nerve or ulnar, which we touched upon a bit when we talked about carpal tunnel syndrome with the joints of the wrist. The median nerve will tend to take care of more of the lateral musculature, whereas the ulnar nerve, because it runs along the ulna, will take care of most of the median portion of the forearm, the wrist, and also the hand. One thing I forgot to mention, the brachioradialis muscle is also going to be innervated by the radial nerve. It's one of the few muscles on the anterior that's going to be innervated by the radial nerve. So here's a quick chart straight out of your book that you can look over at your own leisure. But again, your forearm flexors will include the biceps brachii, the brachialis, and brachioradialis muscles. Basically, your biceps brachii and the brachialis muscle will do exactly the same thing. Flex the forearm at the elbow joint. The biceps brachii will help supinate the forearm and also flex the shoulder at the same time. The biceps brachii and brachialis will both be innervated by the musculocutaneous nerve and partially by the radial nerve for the brachialis muscle. The brachioradialis muscle, also known as your drinking muscle, this muscle will help return the hand to neutral between two positions of extreme supination and extreme pronation. It's going to be innervated by the radial nerve. Your forearm extensors are going to include the triceps brachii, which is going to do just the opposite of what the biceps does. So these are going to be antagonistic muscles. These will extend the forearm at the elbow joint, also partially extend the arm at the shoulder joint. The anconeus muscle, if it's present, will just help extend the forearm at the elbow joint. Both are innervated by the radial nerve. These are both posterior upper arm muscles that enact any kind of function on the forearm extensors. So again, radial nerve contributing. The forearm pronators are going to include two muscles, the pronator teres, which is going to be most proximal, pronator quadratus is going to be most distal. Both are going to pronate the forearm and again be innervated by the median nerve. You have only one major supinator called the supinator. Thankfully, it's easy to remember. It's going to supinate the forearm at the radial ulnar joint. It's going to be innervated by the deep radial nerve. But if you just put down radial nerve, that's more than enough. Okay, this can be a little daunting at first when we first examine this. Fortunately, what they do is tutorial will actually segment this into three different sections here. So you have the anterior superficial view, intermediate view, and the deep view. The nice thing about the muscles of the forearm, wrist, hand, and the digits is the name very simply tells you what they do and also what they move and where they're located. So very simply, if we look at the left diagram there, the thickest part of the forearm is going to be the brachioradialis muscle that we just talked about a few minutes ago. That's going to be the drinking muscle that we talked about. Again, it's going to be the one that returns your hand to neutral from extreme supination and extreme pronation. So as we go more to the medial side, so going more towards the ulnar side, next you have what's called the flexor carpi radialis. So if you break that down, it flexes the wrist and attaches to the radius. You go a little closer in. Next is the small muscle tucked in just underneath there called the palmaris longus. So basically it's a long muscle attached to the palm. It's going to help flex the wrist and the hand. Go a little further in. You got the flexor digitorum superficialis. So it's a little bit deeper to the flexor carpi radialis. So basically what this does is there's a superficial version of the flexor muscles that will flex the digits. So it flexes all the major digits except for the thumb. The thumb has its own flexor muscle we'll talk about in a couple seconds here. So again, just still looking at the left diagram there, then next you get to flexor carpi ulnaris. So notice you have a flexor carpi radialis, you have one for the ulnaris. So the flexor carpi ulnaris is going to help flex the wrist. It's going to attach onto the ulna in particular. The extensor, skip for a quick second here, go a little further down, skip the flexor digitorum superficialis. You also have the flexor pollicis longus. You'll notice the thumb in particular has its own particular muscles here. So the flexor pollicis longus, what they'll do is help flex the thumb. So if you have a flexor pollicis longus, you sure there's going to be a brevis, which I'll show you in just a few minutes. If you look at the intermediate view, so the middle portion here, it's a great shot of the flexor digitorum muscles. The superficialis is here how it partitions the four digits. If you go to the next slide over, if you have a superficialis, you can have also what's called a profundus, which very simply profundus means deep versus superficial. So from a palpation standpoint, it's very tough to actually palpate the flexor digitorum profundus. A lot of patients that I see, especially with any kind of tendinitis or any kind of muscle spasm form, usually it's the flexor digitorum superficialis we're usually palpating at that point. You're going to have the deep muscle there, the flexor pollicis longus, so it's exposed a little bit more for you there. Again, so it's going to be a flexor of the thumb. It's going to be the long portion. We'll show you the brevis in just a few seconds. Now, again, looking at the innervation of most of these, primarily most of the muscles that are going to be on the radial side, and I'll show you a couple exceptions, are going to be generally innervated by the median nerve. Most of the ones on the ulna side are going to be innervated by the ulnar nerve. The one muscle that's going to be innervated by both is going to be the flexor digitorum muscle, which we'll look at the next chart. Okay, so this is the posterior version of the forearm muscles of the wrist, hand, and the digits. Okay, we're going to work our way from the ulnar side to the radial side. So we're going to go from medial to lateral this time on the posterior superficial view on the left. So first you see the flexor carpi ulnaris. It'll still take up the majority of the posterior portion of the forearm. As we go a little more lateral, you're going to see a real thin muscle there, a little bit deeper to the flexor carpi ulnaris. You're going to have the extensor carpi ulnaris. So these are going to help extend the wrist, and it's going to attach into the ulna. Just pancaked in between there, you're going to have the extensor digitorum muscle. If you go a little deeper than that, you're going to have the extensor digiti minimi a little down distally, just before you get to the extensor retinaculum. The extensor digiti minimi is going to very simply extend your pinky. Just a nice little term for that particular muscle there. It's very thin, very short. Very thin and very somewhat weak muscle in particular. So your pinky really doesn't extend quite that much. So again, the extensor digitorum muscle, there is no superficialis or profundus. There's simply just one extensor digitorum muscle. Go a little more lateral to that. You run into the extensor carpi radialis brevis. Go a little further from that, you have the extensor carpi radialis longus. So you see the paired muscles right through there. One literally lays on top of the other. So the extensor carpi radialis, both brevis and longus, will help extend the wrist and attaches into the radius. If we go over to the next slide, diagram on the posterior deep view, they've taken away the extensor digitorum muscle, so you can see very simply some of the muscles of the thumb. So in particular, you have the abductor pollicis longus, which helps abduct the thumb. You've got the extensor pollicis longus, which help extend the thumb. And there's a very distinct way of differentiating between what actual muscle action we're talking about for the abduction of the thumb versus extension of the thumb. We didn't measure this in the lab because it can be a little bit confusing, but very simply, if you think of it this way, abducting the thumb takes the thumb away from the plane of the hand. So if you have your hand out flat with palm up, if you point the thumb straight up, that's going to be abduction. When you bring it back down to the plane of the hand, that's called adduction. Extension and flexion of the thumb. Very simply, if you bend the thumb in any particular plane in towards the palm, that's flexion. When you go away from it, it's extension. It's a little bit different than what we kind of learned in class for the rest of the motions of the joints in the anatomical position. But the thumb, again, being a very unique joint, at the saddle joint, it's going to have some very distinct motions there at the same time. And last one we'll show here, or last two I'll show here. If you have an extensor pollicis longus, you of course have an extensor pollicis brevis. You see it's tucked underneath the longus muscle right through there. It's going to be the abductor pollicis longus and the extensor pollicis brevis. They're going to be involved in decorvating syndrome we talked about before, where the tendon literally clamps down the nerve and causes a lot of tension on the sheath where the tendon is going to pass through. It's a very painful kind of process. And last thing I'll show you there is the extensor indicis, which can help extend the index finger. Here's another shot of the carpal tunnel, which we had talked about before. So again, you realize how small the median nerve is and how tucked in it is at the median nerve, at the carpal tunnel. All different structures around it that can cause any kind of disruption. You have spasm of the thenar muscles, which is going to be the thick pad or the thumb pad. You're going to find a lot of small muscles we'll talk about in a few seconds here. If they happen to get tight, if you have any kind of inflammation of either the synovial sheaths of either flexor digitorum muscles or the tendon of flexor pollicis longus, or of any kind of inflammation of the flexor retinaculum, It can cause a lot of disruption through there. If you get a subluxation, meaning that if one of the bones of the carpals will shift, that also puts some pressure there on the carpal tunnel at the same time. We do see a lot of this of carpal tunnel-like syndromes, where there's a lot of disruption with the wrist, numbness, tingling, weakness in the hand. But the actual carpal tunnel syndrome is actually relatively rare. So let's talk about innervation real quick here. So again, the forearm flexors, biceps brachii, muscocutaneous nerve, brachioradialis, muscocutaneous radial nerves, and brachioradialis radial nerve. Yeah, I do know this is going to be it's a slide we just looked at before, but in particular I want to mention because the forearm is going to contain the pronators and the supinators there at the same time. You see mashed up against all the flexor carpi muscles and also the extensors, as well as some of the small muscles that are deep to the forearm. So let's look at the anterior compartment of the forearm. So all the muscles on the radial side, including the flexor carpi radialis and the palmaris longus, are going to be innervated by the median nerve, as well as the flexor digitorum superficialis, also by the median nerve. The flexor carpi ulnaris will be the only oddball. They'll be innervated by the ulnar nerve because it's going to be on the ulnar side. Go deeper into the compartment of the forearm, the flexor pollicis longus, again, median nerve. The flexor digitorum profundus, because it's the deepest portion of the compartment of the forearm, it's going to be innervated by both the median and the ulnar nerves. It does change from person to person. Some have more innervation on the ulnar side, some more on the median side. All the extensor muscles, all can be innervated by the radial nerve. So it doesn't matter if it's carpi radialis, longus, or brevis. The extensor digitorum muscles, the digiti minimi, or the carpi ulnaris, all innervated by the radial nerve, and are all going to pretty much extend whatever body part that they're attaching to. So extensor of the carpes or the wrist, extensor digitorum, all the digits. The digiti minimi is for your pinky or the fifth digit, and the carpi ulnaris can be for the extension of the wrist itself on the ulnar side. Looking at the really deep compartment of the extensors, again, these are all innervated by the deep portion of the radial nerve. So the abductor pollicis longus will abduct the thumb. Extensor pollicis brevis will extend the thumb. Extensor pollicis longus will work with the brevis with extending the thumb, and extensor indicis will extend the index finger or digit number 2. Now we're only going to worry about certain muscles on this particular slide. The lumbricals that you find deep within the hand itself, we're not going to worry about too much. It's a little bit too much detail and a little bit of minutia in particular, but we are going to look at the two portions of the thumb as well as the pinky area. So we're looking at the lateral and also the medial portions of the hand. We're going to talk about two different types of pads. You have the thenar pad, which is going to be all the muscles of the thumb. You have the hypothenar pad, which is going to be the little slight swelling on the medial side where the fifth digit will find itself. The reason why I mention those two is there's one muscle group in particular I want you to be aware of called the opponens muscles. These are the muscles that help you oppose your thumb pad to the other 4 digits. So your opponens pollicis muscle is going to oppose your thumb to each of the other 4 fingers, except you do have an opponens digiti minimi to help try and draw the pinky in towards the thumb at the same time, almost like in a pinching motion. This is also where you're going to find your brevis muscles of the thumb. You're going to find the abductor pollicis brevis as well as the flexor pollicis brevis. You're going to have one small adductor pollicis muscle. It's going to be found in the webbing of the hand. It's going to be just medial to your thumb and just distal to the index finger. On the flip side, on the ulnar side, you are going to have a flexor digiti minimi brevis and also the abductor digiti minimi, very special for the fifth finger. Again, the lumbricals I'm not going to be too concerned with. I won't really test you on those. As well as the next slide, it goes into interosseous muscle. So you see a better shot of the lumbricals here. Again, this is more for your information here. Next one here, I'll just show you a better shot of the opponens pollicis and the opponens digiti minimi. The dorsal and palmar interossei, I'm not going to test you on. Just be aware of the two opponens muscles that will be very deep to the anterior portion of the hand. And there's the palmar interossei and the dorsal interossei. So looking at the thenar, or the lateral aspect of the palm, we're just going to look mostly at the names of the muscles and what they do. I'm not too concerned with you guys learning the innervation at this point. But very simply, just know what the particular action is of the thumb and where they're going to be located at. So the abductor pollicis brevis is going to, of course, going to abduct the thumb. Median nerve will innervate. The opponent's pollicis, also median nerve. This actually will oppose the thumb to the other fingers. Your flexor pollicis brevis is going to flex the thumb, but also be innervated by both the median and the ulnar nerves. And the adductor pollicis, even though it's going to be on the thenar side, is going to be innervated by the ulnar nerves going to cross over the palm of the hand. When we talk about the hypothenar side, we're talking about the abductor digiti minimi. All of these are going to be innervated by the ulnar nerve, the flexor digiti minimi brevis, as well as the opponent's digiti minimi, all going to be ulnar nerves in particular. The rest of the muscles, the lumbricals, the interossei, just know that they're there. I'm not going to ask too many questions on those particular things. They're more for the real deep musculature, basically for adduction of the fingers, abduction of the fingers, aids with flexion. But other than that, just know simply that they are present in the hand. And we look at the foot, they'll also have their own lumbricals and interossei muscles as well. So let's go to our next question. So think of a minor league pitcher that experiences pain in his pitching arm after throwing about 100 pitches. Doctor diagnosed him with a torn rotator cuff, but the pitcher does not understand what this means. Explain to the pitcher what this means and how this injury could affect arm movement. Now, I actually see this quite often, especially around this time of year with off-season programs. A lot of times some pitchers, whether it be baseball or softball, a lot of times are simply overtraining over the winter break. Now, the mechanism is a little bit different from the overhand throw as opposed to the windmill throw found in softball pitching, but the muscles are very simply the same. So think about, first of all, what four muscles make up the rotator cuff and what they mean by a tear in the rotator cuff. I don't know if you remember, we talked about injuries to the tendons and also the labrum. There's different types of tears out there. It could be a tear in any one of the four rotator cuff muscles, which includes the supraspinatus, the infraspinatus, teres minor, and the subscapularis muscles. So usually any kind of tear in any one of those four muscles is considered to be a torn rotator cuff. Nowadays, most surgeons, at least the ones I deal with from Rothman, as well as RA3Bs or even Penn Orthopedics, they're kind of reluctant to go in and actually try and repair a torn rotator cuff, even though it's done arthroscopically, because a lot of times they can damage more things going in than what they're trying to fix. So for the most part, and this is usually the worst thing that a pitcher can hear, is you have to shut yourself down for about 4 to 6 weeks to see if it'll repair itself, sometimes longer. So it's definitely one of those things where we kind of encourage most of our patients in particular during the off season. It is good to do some pitching drills, but you want to augment that with some other off sport or off season type of activities as well, whether it be weight training, whether it be different type of sport, just something to change things up so you're not causing any kind of too much repetitious type of injuries or overuse injuries. So again, when you're trying to explain this to a potential patient or pitcher, a torn rotator cuff is a tear in either the tendons of one of those four muscles we talked about, or even possibly in the labrum, in the glenoid fossa of the scapula as well. But unfortunately, you're forced to kind of put this person into the price rationale. So it's going to be protection, rest, ice, compression, elevation, and then where you slowly bring back into rehabilitation. Strangely enough, actually my baseball pitchers, we get them actually throwing footballs because the throwing arc for baseball can vary wildly from pitcher to pitcher, but for football there's a slightly smaller window there. It really works on biomechanics more than anything else. As far as the softball or windmill throw, it's a little bit different mechanism. We actually just have them do rotator cuff exercises to stretch certain things out. A lot of times it's the subscapularis muscle that's the one most affected. And also, strange enough, it's also elbow issues. But what I'll do is I'll try and link a video next week or two describing the difference between the overhand throw as well as the windmill pitch. Moving on to the lower extremity, you're going to see a lot of similarities with the upper extremity as far as how the nerves distribute innervation, and you'll see a lot of similar muscles found, especially in the ankle and the foot. They are recognized to be very similar to the wrist and the hand, including the lumbricals and the interossei muscles. But a lot of them in the ankle and the foot will also be named by what bones they attach to, what kind of the actual action that the muscle will attain as well. But for the most part, let's look at the pelvic and the hip bones as the muscles will interact with each particular spot. So even though this particular slide, not all the muscles that I'd like to see on the slide are in bold, but I'm going to point them out to you anyway because some are very important. First thing to look at is going to be the what's called the femoral triangle, which is going to be formed by one ligament and two muscles. Very important because you have three very specific structures that can be found within that area. In the femoral triangle, you're going to find the femoral nerve, the artery, and vein. And this is going to be partitioned by the inguinal ligament, which is going to run from the ASIS to the pubic symphysis. And this can be bordered laterally by the sartorius muscle, which is a long wandering muscle that runs from the ASIS and going to cross over your quadriceps and insert into what's called the pes anserine area, which is the medial portion of the knee. And then you have the pectineus muscle, which is going to form the medial border of the femoral triangle. Basically what you find here with those three structures, nerve, artery, and vein, these tend to get impinged quite often by different segments of the population, some by people that have excessive weight gain, pregnant women, as well as people that wear tool belts. So for example, most times you'll see police officers, construction workers that generally wear a very heavy tool belt will lay on the inguinal ligament and press upon the femoral nerve, artery, and vein. This can cause numbness, tingling. In some extreme cases, it can cause a loss of function of some of the muscles that travel down the anterior portion, in particular, of the thigh. But a lot of times you do see this in the morbidly obese as the belly hangs over that particular spot and it basically chokes off those three structures. Besides causing them some tingling, especially if you occlude the vein in particular, cause a lot of swelling down in the lower extremity, especially pulling down by the feet. You see this in pregnant women sometimes, depending on how the baby will carry, especially if it's more in a forward position. You will see this actually will relieve itself once the baby is delivered, which unfortunately you don't really see with the people that are morbidly obese. They have to lose the weight in order to improve function, which can be quite challenging in some aspects. You also see this in dental hygienists as they lean over one particular portion of the old dental chairs. If they don't have the removable arm, you can press upon the one side of their pelvic region, cause some disruption through there as well. So again, left too long, it can cause irreparable nerve damage and cause some serious issues there too. For the most part, this can be preventable, but you do see this happen quite often, especially in practice. So let's move into the actual muscles themselves. So if we look actually superior to the pelvic bone, there's two muscles in particular I want to point out to you. One is going to be the quadratus lumborum, which we talked about before, in the axial skeleton. If you go just medial to that, you're going to see two muscles that are going to form what's called the iliopsoas muscle, which is going to be comprised of the psoas major and the iliacus muscle. A lot of times they are simply just termed either the iliopsoas or the psoas muscles. These are very important because they do a couple different functions. In particular, the psoas major is going to attach directly into the vertebra of the lumbar spine and occasionally into the discs there at the same time. So it shows a very intimate relationship between the muscles of the lower extremity as well as the lumbar spine. This muscle tends to get very tight on patients, in particular those who sit. The iliopsoas muscle does a couple different things for us. Number one, it will help flex the lumbar spine forward. Also, it'll help flex the hip and also flex the pelvis at the same time. So this muscle tends to get tight. It can literally sandwich the discs of the lower back. This will further inhibit the lower abdominal muscles, especially the last, or I should say the most inferior portion of the quote-unquote six-pack. So it allows the pelvic area to actually extend forward and actually open up the forward aspect of the pelvis and also sandwich L5 and S1 together and literally jam the joints back through there. So the iliopsoas muscle, if it tends to be a little overpowered, it can actually cause a lot of disruption with the lumbar spine as well as the pelvic area at the same time. We'll look at later where the glute max, in particular the hamstrings, will be fighting against this quite often. But unfortunately, as we sit, your glute max as well as the hamstrings tend to get inhibited, so the iliopsoas muscle tends to get very tight. And unfortunately, it gets tight asymmetrically at the same time. A lot of times you'll get little kinks, almost formally very minor scoliosis in the lumbar spine. But let's talk about some of the other muscles that are found just inferior to the pelvis and crosses over the actual hip joint itself. The sartorius muscle we talked about before. This is a weak muscle that does a couple different things. It will flex the hip. It will also help marginally, will extend the knee, but is also a major lateral rotator for the hip. It works in conjunction with a bunch of other muscles that we'll talk about in a few seconds here. But the main muscle group you want to look at is going to be the quadriceps. The quadriceps is made of 4 muscles. It's a very strong muscle. We'll see that has a very high cross-sectional area. The quadricep muscle is made of 4 muscles, which is the rectus femoris, which is the longest muscle of the 4 and the strongest of the 4. Just deep to that, you'll find 3 muscles called the vastus lateralis muscle, intermedius, and the medialis muscles. The lateralis muscle is occasionally going to be stitched to the iliotibial band, which is going to have the tensor fasciae latae muscle, which is not shown here, but runs from the iliac crest and attaches to the superior aspect of the iliotibial band or tract. For most people with a repetitive stress, runners in particular, you see that muscle get very, very spastic and get tight. It actually will tug on the patellar tendon. If you remember, when we talk about the Q angles with runners, that can cause a valgus deformity and put a lot of pressure on not only the patella but also the patellar tendon as it attaches the tuberosity, and also will disrupt the menisci, especially the lateral meniscus in particular. So what winds up happening is the vastus lateralis muscle gets very tight, and also the vastus medialis muscle gets very weak by comparison, because a lot of times it's inhibited by too much spasticity in the lateralis muscle. So we'll have some patients actually do a locking out of the knee because the vastus medialis muscle is really only used in the last 5-10 degrees of knee extension. So the quadriceps as a whole will extend the knee. The rectus femoris only out of the 4 muscles will actually work as a hip flexor as well. So only the rectus femoris acts as a hip flexor. The quadriceps on their own will help extend the knee. The other muscles I want to point out to you as well are going to be your major adductors. These are also going to help with medial rotation of the thigh. You've got the pectineus muscle, which is a strong adductor. It's going to be paired with 3 adductor muscles, the longus, magnus, and brevis, and then most medial will find the gracilis muscle. This is the muscle which alone as an adductor and a medial rotator is also one of the muscles that a lot of times we get a quote-unquote groin pull. Usually going to be one of either the gracilis muscle or oftentimes the pectineus muscle. And these usually have to be stretched out quite often, and normally because it's a sensitive area, it's definitely something that you want to make sure you keep stretched out both pre and post exercise. So here's a deeper look into the gluteal muscles that move the femur, so you get a better shot of the adductor brevis muscle as well as the adductor magnus. So they work in concert with the adductor longus, the gracilis, and the pectineus muscles. A couple other small muscles you'll find there is the obturator externus. We'll look at that a little more closely when we look at the posterior version. Basically, all your adductor muscles will also help medially rotate the knee, medially rotate the thigh. The obturator externus is going to attach around the obturator foramen, actually help laterally rotate the thigh. And I'll talk about a mnemonic to help remember the real small muscles. There are 5 muscles there. We'll talk about that in a couple seconds. So let's look at the posterior region. So most people are familiar with glute max. The gluteus maximus is going to be your major hip extensor. It will actually help stabilize the pelvis at the same time, and also help laterally rotate the thigh, helps lock the knee into full extension. Basically, it's the glutes that we use, especially with deadlifts. It's a nice little accessory muscle that bridges the gap between the paraspinal muscles of the spine and the hamstrings. These are going to be major extensors. Unfortunately, the glute max tends to be inhibited a lot because we sit on it all day long, and that allows that iliopsoas muscle to run amok and get too tight and too strong. Now, the glute medius, paired with the glute minimus, which you don't see here, but it's just deep, the glute medius, these are going to be major abductors. And these will also help with stabilizing the hip, and also will help medially rotate the thigh at the same time. Here's a deeper cut looking into the lateral rotators this time now of the hip and also the hamstrings. But let's look at the lateral rotators first. There's going to be 5 lateral rotating muscles found therein. We use the mnemonic of please suck on it quickly. It's not the best mnemonic, but that's what we learned back in school. So it's going to list the piriformis, the superior gemellus, the inferior gemellus, the quadratus femoris, and the obturator externus, the obturator internus, pardon me. So please suck on it quickly. So the piriformis, the superior gemellus, the obturator internus, the inferior gemellus, and the quadratus femoris are all going to be lateral hip rotators deep to the femur. Here's a nice little shot of the hamstrings there as well. So the hamstrings are going to be a set of 3 muscles, and going from the medial to lateral, it's the semimembranosus, the semitendinosus, and the biceps femoris. The biceps femoris is going to have 2 heads, attaches into the femur. The biceps femoris, the long head as well as the semimembranosus and tendinous are going to attach into ischial tuberosity. That's what we call the sit bone, and it's going to attach into the tibia. So this is going to be major hip extensor as well as a knee flexor. In particular, the long head of the biceps can be a very major knee flexor and also aids with hip extension at the same time. So here's a nice little cutaway, the deep views of both the anterior and posterior deep muscles. So it gives a nice little shot of the pectineus muscles and the other adductors in the top view. This also partitions different muscles of the quadricep in the middle views there, the anterior, and then again for the muscles that make up the hamstring. So let's talk about innervation. So again, the arch insertions I would be relatively familiar with. This does give you an idea of what kind of actions each particular muscle will have. But in particular, when we're looking at the anterior portion of the femur, generally it's going to be the femoral nerve. The lateral can be split in different gluteal nerves. Some of the small muscles have their own nerve. Like if you look at the obturator internus, it simply has a nerve to the obturator internus. So not much ingenuity there on naming that particular nerve, but it does make it easy to figure that one out. So again, looking at the iliopsoas, the lumbar spinal nerves, L2 to 3, will form the psoas major. The other portion of the iliopsoas, the iliacus, is going to be innervated by the femoral nerve. The gluteal nerves, if you look at the glute max, because it actually is the most inferior of all the gluteal muscles, it's going to be innervated by the inferior gluteal nerve. Your glute medius and minimus, as well as the tensor fasciae laticus, are all roughly in the same area, all innervated by the superior gluteal nerve. The piriformis nerve, which is a very strong lateral rotator, we see this is a very special muscle because in the small segment of the population, roughly 10–50%, the sciatic nerve that branches through the area actually will pass just superficial to the piriformis, actually may pass literally through the piriformis. So when we see any kind of spasticity to the piriformis, it can mimic sciatica. It can cause the same kind of pain, which we'll deal with sciatica in a little bit. Just very similar to the carpal tunnel syndrome. A lot of people swear up and down they have sciatica, which unfortunately is a very problematic type of condition, but it's actually very rare at the same time. Has a lot of check boxes have to be checked off actually to physically have sciatica. But piriformis muscle is innervated by sacrospinal nerves, S1 or S2, typically more so S1. Now the deeper muscles, this is where again strict memorization is going to come into play. The obturator externus muscle is going to be the obturator nerve. The superior and inferior gemellus muscles will each have their own innervation, so the nerve to the obturator internus will share to the superior gemellus. Nerve to quadratus femoris will also innervate the inferior gemellus there as well. Your adductor muscles, for the most part, are going to be innervated by the obturator nerve. Only the magnus will also have some innervation from the sciatic nerve. Odds are I would probably not ask you that specific innervation, but I do group them at 3 adductor muscles, and if I ask what nerve will majorly innervate them, obturator nerve would be the answer there. The pectineus again is going to be oddball here. That's where the femoral nerve, because it's a little more to the anterior in the femoral triangle, it's going to be innervated by the femoral nerve. Okay, and also the adductor muscles, as well as the gracilis and the pectineus, they group these as the medial compartment of the thigh. All the adductors, again, obturator nerve will be the major innervation. Now looking at the quadriceps and the sartorius, they're grouped pretty much together. If you're looking at any of the anterior compartment of the thigh in particular, odds are the femoral nerve is going to be the major muscle there. The femoral nerve does stop though just anterior and superior to the knee. so you won't find the femoral nerve innervating anything below the knee. Now, as far as the posterior compartment, all the hamstrings, the sciatic nerve per se does not really innervate any one particular muscle group, but there are two nerves actually stitched together to form the sciatic nerve. One's going to be the tibial, one's going to be the fibular, but for the most part, for the hamstrings, the tibial nerve, which is going to be the most posterior nerve that you're going to find, will innervate the hamstrings. The tibial nerve actually will split just above or sometimes at the knee into the common or the superficial or the deep tibial nerve, which we'll get into in a little bit. We get into the lowest part of the extremity, the most distal part of the lower extremity. So here is a cross section of the thigh. Here you're going to see, for the most part, a little more cross-sectional area in the vastus muscles, as well as sartorius and rectus femoris. In particular, if we did the hamstake lab, most of you would get the thigh, and it's kind of quite simple to kind of see where the different compartments are. In this case, you see the femur is slightly offset. The hamstrings have a decent cross-sectional area. You see the medial compartment here by the adductor muscles. But for the most part, the anterior compartment or the quadricep muscle is going to dominate most of the cross-section area you see here. So naturally, that's going to be the strongest muscle out of the three groupings here. Okay, we'll move into the distal portion of the lower extremity. So we're going to look first on the left side, the anterior superficial view. We're going to talk mostly about the anterior muscles here, even though it's going to show some of the calf muscles. I want to focus more so on the anterior compartment. The tibialis anterior is going to be the most noticeable for most people. This is your shin muscle. This is where most people get their shin splints. The tibialis anterior is going to run from the tibia. It's going to run down the anterior compartment of the shin. This is one of your major dorsiflexors of the ankle. These tend to get overused, especially when people are doing a lot of treadmill work or do a lot of stair climbing. The muscle does not get much of a chance to really elongate or stretch out. It's also a very tough muscle to stretch out there too. You're also going to find most of your extensor muscles as you extend the toes or extend the ankle. In this case, you're going to see the extensor digitorum longus. Again, very similar to what you see in the forearm and the wrist. You're also going to see what's called the fibularis muscles on the lateral side here. These were the older names for the fibularis muscle was known as the peroneus muscle. I may use those interchangeably. There are three fibularis muscles, the longus, the brevis, and the tertius. The longest is going to be an everter, so it's going to flare the foot in abduction and flare the ankle in abduction. The fibularis brevis will aid in that particular motion. The fibularis tertius is actually going to do a totally different function completely, which we'll talk about a little bit. It's actually a little bit more of a dorsiflexor for the foot. You're going to see the extensor hallucis longus muscles. The hallucis will be for the big toe. Of course, if you have longus, you're sure there's going to be a brevis there as well. You also have the extensor digitorum muscles. Again, all these are going to be major dorsiflexors of either the digits of the foot or the big toe. If you do look on the right diagram there, it does show the gastrocnemius, which paired with the soleus. These two muscles are going to form the calf muscle. The gastrocnemius is going to cross over both the ankle and also the knee. So it's going to be a plantar flexor in conjunction with the soleus muscle. But it's also going to help in aiding weakly. It's going to help flex the knee at the same time. Most people, if you're going to have any kind of chronic tension, you're going to see more tension in the soleus muscle, which is actually more of a postural muscle. This is the one that actually keeps you upright so you don't lean too far forward and fall over. Your gastrocnemius muscle is more your explosive muscle. You're going to run. But both of the muscles will attach into the Achilles tendon. So you're going to get any kind of Achilles tear. Usually it's because the gastrocnemius or soleus muscles are too strong and it causes some fraying in the Achilles tendon and eventually may tear altogether. Quite painful. You don't want a complete tear. It's quite a nasty style of injury, which I have seen in the past. Literally, it's like it rolls up almost like in a like blinds, like so to speak. It's a nasty, nasty injury. Okay, so the posterior compartment. So again, we're going to look at a couple different things here. Look at the left. There's the gastrocnemius. It has two heads. It has a medial and lateral head. You see the soleus muscle is going to be relatively flat. It's going to lay just deep to the gastrocnemius muscle. The soleus muscle will not cross over the knee, so it is mainly a plantar flexor for the ankle. But like I said before, it does get chronically tight. Most of you have ever done a runner stretch before, it does, for the most part, go after the gastrocnemius muscle, but unless you bend the knee and kind of lean into the stretch, which unfortunately I can't show you here, the soleus muscle can stay tight and actually cause some disruption with the heel there at the same time, where the calcaneus a lot of times will actually jam itself into the talus. Most people, you take that first step out of bed, if that soleus muscle is too tight, you're going to feel a lot of achy pain when you first take that step out of bed as you load up on the calcaneus and as that pushes up into the talus bone. So it's definitely something we work on in our office quite often. Looking a little bit further superior to that, you're going to see a small muscle there called the plantaris muscle. There's another muscle that's going to be linked to that. It's going to cross cross diagonally across the back of the knee, called the popliteus muscle, which you can just barely see on the right side there. These muscles are very integral to how well the knee or the corkscrew maneuver as the femur is going to load up on the tibia. If either one of those muscles gets to be too tight, you can actually start wearing down the menisci and a little more motion than the knee than it's supposed to. So you have a little more weight-bearing structures on the ACL and also the PCL at the same time. Now looking at, if you cut away both the gastroc and the soleus, you have the tibialis posterior muscle. That's going to be another ankle dorsiflexor. There you see the fibularis longus muscle there as well. Your flexor digitorum muscles are also going to be found there at the same time. So these are going to help flex the toes, whereas the extensor muscles found in the anterior compartment are going to extend the toes. You have your flexor hallucis longus. The flexor hallucis brevis will be found deep within the foot. So again, these muscles are going to help flex the toes or flex the big toe, and also will weakly aid in plantar flexion of the ankle. So here's some deep shots of the leg muscle moving the foot and also the toes. So the anterior views, you can see the tibialis anterior again, your major shin muscle. You're going to have the extensor hallucis longus and fibularis tertius. You're going to see the extensor digitorum longus there too, again for extending the toes. You have a nice lateral shot there of fibularis longus and fibularis brevis. These could be your major everters for the ankle. Looking at the posterior portion, you're looking at the gastrocnemius and the soleus, and also the plantaris muscle will help. The gastrocnemius at least will help flex the knee, but they all are major plantar flexors for the ankle. There's tibialis posterior muscle also for the portion of the deep compartment of the posterior portion of the lower leg, also a major plantar flexor. And of course there's the popliteus muscle. As you see, it wraps around the lateral epicondyle, wraps into the posterior portion of the tibia. This muscle allows the proper loading, again, of the corkscrew maneuver. A lot of times this muscle can go into spasm, which makes walking very difficult. A lot of times it causes disruption on the medial and lateral meniscus in particular. One thing I did forget to mention though, the muscle that for the most part will invert the foot will be the tibialis anterior muscle. Will help invert the foot just by virtue of where the attachment point will be on the medial edge of the foot, at the medial metatarsal 1 and also the first or medial cuneiform. All right, so let's talk about innervation. So we're talking about the sciatic nerve where it branches off into the tibial and the fibular nerves. Now the tibial nerve will branch off roughly either just superior or just at the knee. So this causes some problems in particular with some issues with the popliteus muscle. A lot of times you'll see if that muscle goes into spasm, it can irritate the tibial nerve and cause a lot of tingling and numbness down into the toes. Now the tibial nerve, very similar to the radial nerve found in the upper extremity. The tibial nerve is going to innervate the majority of your posterior muscles, both in the posterior compartment and also the deep posterior compartment. So the gastrocnemius, the soleus, and the plantaris muscle all innervated by the tibial nerve. You'll find the popliteus, tibialis posterior, almost all the flexor muscles also going to be innervated by the tibial nerve in the compartment there. One thing I do want to mention too as well, the plantaris muscle is not found in everybody. It's actually a very small muscle. It actually can be fused with the calcaneal tendon. Only a certain percent of the population, I think it's down to like 7% of the population, still has the plantaris muscle. So from an evolutionary standpoint, that's kind of getting phased out. From what I remember, I believe the plantaris muscle is involved in some of the smaller primates, especially without the opposable toes. Again, I can't be 100% sure on that one. I'll provide a little more research at a later date. Now, looking at the lower muscles, especially with the anterior compartment of the lower leg. So if you remember before I talked about the femoral nerve for the anterior compartment of the thigh stops just superior to the knee. So when the when the sciatic nerve will split into the tibial and the fibular nerve is going to branch into the anterior compartment of the lower leg. So we have two types. You have the deep and the superficial fibular nerves. The deep nerve of the fibular portion is going to go more towards the medial and the anterior portion. So the tibialis anterior and the majority of your extensor muscles are going to be innervated by deep fibular, otherwise known as the peroneal nerve. The lateral compartment, in particular the fibularis longus and fibularis brevis muscles, are going to be innervated by the superficial fibular nerve, or otherwise known as the superficial peroneal nerve. As you can see here, the fibularis tertius muscle is going to be a little bit different than the other two muscles, where not only does it help evert the foot, but also will help dorsiflex the foot, which is in direct competition with the fibularis longus and brevis muscles. They will help plantar flex the foot as well as evert. So again, most of your extensor muscles, especially found in the dorsal portion or the anterior portion of the lower extremity. Again, deep fibular nerves, especially with the extensor hallucis brevis and the extensor digitorum brevis, both innervated by a deep fibular nerve. Now, out of this whole diagram here, there's only one muscle I want you to be aware of. That's the flexor digitorum brevis, found on the left side here. The flexor digitorum brevis is very important because this interacts with the plantar fascia, which is cut there. It's actually known as the plantar aponeurosis. So the flexor digitorum brevis muscle will split to 4 toes. Okay, so the 4 lateral toes, so digits 2 to 5. This muscle tends to get very tight on a lot of patients, especially with improper foot mechanics. This is where orthotics come into play. The flexor hallucis brevis muscle is just medial to that. It can also be implicated there as well. If either one of those muscles tend to go weak, then a lot of times we see the flat foot occur quite often. So, okay, I lied. So there's 2 muscles I want you to worry about. One is going to be the flexor digitorum brevis and the flexor hallucis brevis. 2 major muscles that I want you to know about, very simply because it helps form the arch of the foot, maintain the arch with the plantar aponeurosis. The rest of the muscles, if you want to take a look at them, that's fine. This basically is mirrored a lot with the muscles found in the hand and the wrist, as well as the fingers, but I won't be testing on that quite as much. Just so we know where, if I did mention, if we saw the flexor hallucis brevis, you know that's part of the flexor muscles for the big toe, but I'm not worried with the innervation, not worried with the origin insertion for these at the same time. Now, one other thing I want to point out as well here, which we'll talk about in a little bit, the flexor digitorum brevis is a muscle that a lot of times when it gets too tight, it actually will tug on the plantar aponeurosis and cause heel spurs. So that's basically calcification of where the tendon actually meets into the bone. If this gets too severe, and a lot of times you can see a little hook on x-ray right at the calcaneus, you have to go see a podiatrist, have the foot opened up surgically, and have it shaved down. It's not a fun procedure, but it's something that a lot of my patients, especially the obese or people that have diabetes, a lot of times will get that surgery done to try and alleviate some tension and pain from the foot. Here's the plantar interosseous muscles, very similar to the hand. There's your dorsal-interosseous muscles. All right, so again, there's only a handful of muscles here, just 2 muscles I want you to be familiar with. If you look under the first layer, the plantar muscles, the flexor digitorum brevis, that's going to be innervated by the medial plantar nerve. It's going to be a branch of the tibial nerve, as well as the flexor hallucis brevis. Again, also going to be innervated by the medial plantar nerve. Again, these are the only 2 muscles I want you to worry about, the flexor digitorum brevis and the flexor hallucis brevis, and the interaction of what it does in regards to how well it can maintain the plantar fascia and maintain especially the longitudinal arch of the foot. Okay, so let's talk about the contributions of the muscular system in general. So we know obviously that it produces body motions, so simply walking, just simply moving things from one place to the next, like say stacking dishes, moving things from a washer and dryer. They also produce the body movements. It'll help stabilize body positions, so from a standing position, staying in attention. Those in your ROTC know full well what that means. Also try and stabilize body positions while you're sitting in front of the computer. Unfortunately, it's the fatigue that a lot of us deal with trying to maintain that stabilization. We a lot of times will get too tired and fall in that forward hunch position and cause all kinds of havoc with different body parts. Obviously, the muscular system will also move substances through the body. So we know the smooth muscle obviously will move different things through the gastrointestinal tract as well as the genitourinary. If you look at the skeletal muscle system, especially with the venous system, because there is no real pressure to the venous system, simply contracting certain muscles will push fluid or edema through those particular systems, so it prevents pulling in especially lower extremities in particular. So that's why a lot of times rehab is very important. Post-injury, as long as something is not unstable, we at least have patients start doing range of motion exercises to alleviate any kind of pulling or edema in the body. And of course, the major thing that we see with the muscular system is with the heart. It obviously moves blood through the body. Naturally, it also produces heat, maintain normal body temperature. So skip down to the shivering. That's going to be involuntary contraction to maintain your body temperature. But that also, the production of heat also, not only to maintain body temperature, but also to make sure that you can burn fat and also take some pressure off the body, especially for the overweight and the obese centers of the population. The other thing is too, we'll see when we get into reflexes and muscle tone, it does provide feedback to the central and the peripheral nervous system. So obviously, especially when we talk about motor control, if we're doing something very finely tuned or very delicate, basically provides feedback to allow proper contraction of the muscle so we don't break something, don't squash something. Those of you who do any kind of balance work, do any kind of yoga, obviously that provides feedback as far as body positioning, which we'll talk about in particular what we call proprioception. We start talking about just being able to orient yourself in space. So if you're going into, say, tree pose in yoga, where if you close your eyes and try and maintain a position, you obviously know where your hands are in space. You know where one foot is up, laying up against the knee, so you help maintain that proper position. So it's the sense of feedback that you're getting from those muscles and how they're oriented, how they're contracted, that gives your central nervous system an idea of what to do next, whether you have to reposition yourself or basically change position to avoid falling, that kind of thing. All right, let's talk about running injuries. So most running injuries that we see involve the knee. And the knee, as I mentioned before, is the biggest joint in the body. It will also compensate for a lot of different injuries there to the foot, to the ankle, to the hip, to the lower back. Most oftentimes, unless there is direct trauma to the knee, if there's pain in the knee, odds are it's coming from some other faulty biomechanics. So it's usually related to poor training techniques or altered biomechanics, like say from previous injuries or repetitive stress. We do stress to a lot of people in particular that even though if you may just enjoy running, it's also good to augment that with different balancing exercises or do certain strength training exercises. So this way you're at least challenging certain areas of the body, whether it be the muscles, the joints, a lot of times the tendons, a lot of times need to be triggered in certain ways to kind of maintain proper positioning, proper strength. But we do see a lot of tendinous type of injuries with repetitive stress and the altered biomechanics. Sometimes you may need to alter your workout plan. Sometimes you might need outside intervention where you may need orthotics or change in running shoes or just simply changing in different training techniques or trying to change things up. For most patients, we tell them to try and change their workout routine every season, so once every 13 weeks, let's say. Even it might be changing the sequence of certain muscle groups they may use. Some people like to do small muscle groups first and do larger after, or vice versa. They may work antagonistic muscles in the same day, but simply just change the sequence a lot of times can force the body to adapt and therefore prepare itself for any kind of major activity you may be doing in the future. And of course, as I mentioned before, injuries in particular can first be treated with price, and that's protection, relaxation, ice, compression, and elevation. Sometimes you might need non-steroidal anti-inflammatories or steroid injections, but definitely, especially if we feel like something is not unstable that needs any kind of surgery, you try and start doing rehab exercises relatively quickly, sometimes within hours after an injury. Compartment syndromes. So we've already talked about one in particular with the carpal tunnel. Sometimes you may see this with the ulnar tunnel here, but usually for the ulnar nerve, it's more so up by the medial portion of the elbow. You do see tibial compartment syndrome sometimes, which is very analogous to carpal tunnel syndrome, where a lot of times the tibial compartment, especially at the posterior region, can cause some compression on tibialis posterior muscles. The gastrocnemius cause a lot of different issues there. If left untreated, very similar to what we saw with the femoral triangle and the carpal tunnel, the nerves can suffer damage. As I mentioned before, it does not take a lot of pressure to disrupt an action potential. It takes barely the weight of a dime to alter any kind of transmission of any kind of nerve impulse. Over time, the muscle can also develop scar tissue, and scar tissue over time will contract. That's why a lot of times certain scars on your skin will start to pucker over time, usually about a year or two after. They won't look the same as when they were fresh. But this contractile tissue also acts like a netting with glue, so that can also traction other muscles and draw upon tendons being pulled from bone, ligaments being pulled in different directions that's not designed to withstand, and that can cause some very inherent weakness there at the same time. When it gets very severe, you can get a fasciotomy where the surgeon will cut the fascia to relieve the pressure, but a lot of times that is more of a temporary solution, because a lot of times the cut, unless it's done very precisely, you can cause more scar tissue to develop from there too. So again, this is where the rehab is very important, especially post-surgery. Plantar fasciitis, as I mentioned before. So this is a painful heel condition that results from chronic irritation of the plantar fascia. Basically, it originates at the calcaneus and then splits to the lateral four toes. So again, treatment is roughly the same as any other injuries with the Price principle. Occasionally, though, you may need some kind of prosthetics. In this case, some kind of orthotic, which either podiatrists or orthopedic surgeons, sometimes chiropractors can do this too. In the really severe cases, if the steroid injections don't help, they may need surgery to kind of cut the aponeurosis and let it relax. If left go even look further than that, it can lead to heel spurs, which is the calcification of the plantar aponeurosis. So it starts creating a hook, so to speak. If the hook is sharp, it can actually start fraying away at the plantar aponeurosis. But a lot of times what we do see, it's usually from faulty biomechanics, from repetitive stress. It can lead or be led into from weight loss, because as people start to change how they walk, especially if you start to see with the morbidly obese, they have like that duck waddle, where a lot of times their foot will roll inward to get flat feet. That can also contribute to this kind of plantar fasciitis issue at the same time. So as you can see, it's a long-term problem that a lot of times will need a long-term solution. Myasthenia gravis. This is a special type of disease. It's an autoimmune disease where it causes progressive damage to the neuromuscular junction that we talked about last chapter. So what ends up happening is antibodies will actually attack the acetylcholine receptors and cause a lot of weakness in the muscles, especially the small muscles first. So you can see it a lot of times in the face as well as the neck. You'll see it affect the eye muscles in particular, and then given enough time, it affects the lower muscles, and if really letting go, the respiratory muscles will follow very soon thereafter. And of course, once the respiratory muscles start to go, death occurs very, very soon thereafter. What we found is it can often be a thymus disorder, and a lot of times the thymectomy can be helpful if done early enough before the large muscles start to be affected. Muscular dystrophy. This is oftentimes linked to the X chromosome. Only affects men. In particular, it affects the boys, usually starting ages, toddler age between 2 and 5. This is very important for a lot of parents in particular with young boys. If you start to notice any kind of problem with them falling, jumping, or running difficulty, if the running pattern looks awkward, they're usually checked because we're going to DNA test to kind of see what's going on there. Oftentimes, it's caused respiratory failure by the time you're 20. So what ends up happening is the dystrophin that supports the sarcomeres that attach to the sarcolemma of each individual muscle fiber is simply absent. So what ends up happening is the muscles tear, they rupture, and they don't repair themselves very well. So naturally, if there's enough disruption to the sarcolemma and to the sarcomeres, muscles simply can't contract. And then especially if the diaphragm can't contract, then of course it's going to cause respiratory failure. It's a very nasty disease that so far there is no cure for. Let's start with different terms that you use for abnormal contractions. Spasms are a long-term abnormal muscle contraction that can last for weeks. Spasms can be worked out. A lot of times it takes multiple treatments to get them to loosen up. Cramping is a very painful spasmodic contraction where it's a little bit different than a spasm. A lot of times it can just be a spasm is just a sustained contraction, where a cramp a lot of times is a very forceful contraction, doesn't last very long. It's more of a short-term type of thing. A lot of times they can be rubbed out too. Very painful to get rubbed out at the same time. A tic is known as a spasmodic twitching. It's an involuntary action that is normally voluntary. A lot of us will experience tics, especially around the small muscles around the face. A lot of times you may feel it in the small muscles around the ear, twitching around the eye, sometimes around the fingers and the toes. Normally these last anywhere from a few days up to about a week, but they do go away. It's only when they become a little more frequent, or they become where they don't go away. That's something that usually requires someone taking a look at, like myself or another physician. You'll see tremors sometimes. These are very rhythmic. These are involuntary purpose contractions, such as quiver or shaking. You also get what's called fasciculations, which is involuntary brief twitch. You see this in multiple sclerosis or Lou Gehrig's disease, otherwise known as anterior lateral sclerosis. The difference being between Parkinson's and multiple sclerosis is Parkinson's is when you're at rest. They're called resting tremors. So those of you know Michael J. Fox, very simply, you'll see his hands and see his neck move. Now, if he voluntarily goes to contract those muscles, the tremors go away. The flip side of that is when you have fasciculations. These are involuntary spasms with multiple sclerosis. These are intention tremors. So in other words, while they're at rest, the muscles are fine. They don't have any kind of tremors whatsoever. But if they go to reach for something or they try and walk, a lot of times they lose control of the hand, starts to tremor. The perfect example is they go for for another coffee. They'll spill the coffee pretty easily. There are some treatments for MS. It does tend to oscillate back and forth. They can go into remission. It can be masked by other types of problems as well, but usually is a very chronic condition, which in some cases can cause death. Now, fibrillation, that's a spontaneous contraction of the single muscle fiber. A lot of times you see this in the heart. You may see this a lot of times in the small muscles of the inner ear. Usually means there's destruction of the motor neuron. This usually happens very briefly. Then you lose control of that particular muscle fiber. DOMS, delayed onset muscle soreness. This is something a lot of us deal with. So a lot of times we have the muscle will tend to be sore. Sometimes if you do really strenuous exercise, it can happen within hours after exercise. But for most of us, usually about a day, maybe 2 days of after we're doing any kind of strenuous activity, you'll get delayed onset muscle soreness. So basically what ends up happening is you tear the sarcolemma, you damage the myofibrils, you start disrupting all the Z discs. You have a lot of lactic acid buildup, which is not a bad thing. Basically, it's just a signal for the body to actually lay down more muscle tissue and therefore strengthen the muscle, either from an endurance or a strength standpoint. But it does take a little bit of time for the muscles to kind of catch up a little bit to the rest of the body's inflammatory stage and also repair stage. But during this time, you see increased blood levels of protein, so there's more myoglobin there. It naturally brings in more oxygen, more nutrients. It starts to synthesize more muscle proteins, and new sarcolemmas start to form. For a lot of us, the toughest thing is going back to exercise while you still have DOMS. It's important to get back and do the same range of motion, maybe not quite at the same intensity. We're using the same level of weights, but it's important to keep undergoing that particular repair, because unfortunately, when you have any kind of repair like this, you're going to get inflammation at the same time. And if inflammation left too long can cause scar tissue there at the same time. So to basically disrupt that period of production, you want to try and maintain your exercise as best you can. And for a lot of people that are new to exercise, it's very tough to get them to exercise the second time within a week because of DOMS. So this will segue a little bit when we get into the reflexes in particular, when you start getting into the nervous system. So we're going to talk about two different types of sensory organs found in muscles: muscle spindles and tendon organs. Muscle spindles are going to be special sensory receptors that monitor the stretching of the muscle. They're going to be found in the belly of the muscle. They're going to show change in length, cause contraction. Your typical stretch reflexes. So we do the knee reflex, which I'll actually demonstrate for you through video, probably in the next week or two. We use the reflex hammer to tap on a tendon. The muscle will detect a quick stretch of the muscle. It will contract to basically protect itself from tearing tearing the tendon itself out of the bone. On the flip side, you have what's called tendon organs. In old school they were named Golgi tendon organs. These are going to be found in the tendons themselves, where a lot of times when if we're doing any kind of exercise where muscle goes into fatigue, for those of you who ever helped someone move, a lot of times if you're lifting something that's really too heavy, it's a protective mechanism for the body, so it basically causes the muscle to shut down, which is not exactly the best thing, because if you're carrying something heavy, you could drop it, but it prevents tearing from the tendon and or the muscle at the same time. So there's two slightly different mechanisms here for the muscle spindles and tendon organs, but they're two very special sensory areas found within the muscle. One, spindle is found in the muscle belly itself. The tendon organ is found, of course, in the tendons. Both of them help prevent injury to the muscle and the tendons themselves, but have a slightly different mechanism. So just be aware that one is found in the muscle belly and the other is going to be found in the Golgi tendon organ. So that should wrap up this particular part 2. So you should be ready for the next quiz at this point. This was rather lengthy. Sorry, I got a little bit on my soapbox on some of them. If you have any questions, please email me thereafter. Make sure you answer the one question regarding the torn rotator cuff and submit it as part of your assignment.